Okay, please sit down. And we start with this session on care networks. My name is Helmut Hildebrand. I'm organizing care networks, mainly in Germany, as a company it's called Optimising. And you might have heard of our main project that started already 15 years ago, Gesundes Kindzichtal, and some of you might have read about it. So the first speaker, and just to remind you, this session is live streamed, so we have as well some online participants, and please be sure that if you talk, please take the microphone, and we bring the microphone to you so that the others can hear you as well. So the first speaker is Tim Robbins. Tim is from the University Hospital of Coventry, from the NHS Trust, and he will talk about optimizing an integrated, effective diabetic food service. And I'm looking forward to your presentation. Tim.
Thank you very much, and thank you everyone for coming to listen. My name's Tim Robbins. I'm from the West Midlands area of the United Kingdom, and actually we're not presenting what we've done in Coventry. We're presenting a Midlands-wide network. And during the presentation, you'll hear from two of my colleagues as well, Sarah Hart, who's a podiatrist, and Dr. Namasim Murty, who's a consultant clinician. We have no conflicts of interest to declare. During the presentation, we'll talk a little bit about what is the Midlands Foot Care Network. How do we use the National Diabetes Foot Audit, which occurs in the UK, to drive change in the Midlands? Now, how do we look at individual root cause analyses at a Midlands level? And how can we integrate self-appraisal, peer review, and then bring all of that together? So the Midlands region of the United Kingdom is the middle of the UK. It brings together Birmingham, Coventry, Warwick, Stratford, typically divided into two West Midlands and East Midlands, so Leicester is included as well. And the foot care network across that patch looks to reduce variability in care, looks to improve outcomes, and particularly for diabetic foot disease, it looks to reduce amputations. And the way our foot care network looks to do that is through education, good clinical governance, and collaboration and research, and we're not going to really talk about research today. We're here because we're really excited about what we've done and what we've delivered. We have a peer review network across the entire region. That means that different clinicians in an organisation are peer reviewing clinicians in a different organisation. That's a different hospital, a different primary care setup, very different to how we would normally do it. Root cause analysis training. We've secured extra funding to support our patients. We have a regular attendance from over 100 clinicians, positive feedback, increased participation in a foot audit, timely access for patients in our area to foot disease, and a reduction in major amputations. So, what is a National Diabetes Foot Care Audit?
National Diabetic Foot Audit is a mandatory audit of diabetic foot ulcers, which all providers across the integrated care system take part in. Foot data is captured and anonymised against information from primary care. Particular areas of interest are time from primary care to first specialist foot appointment, the complexity of ulceration at first presentation, and healing outcomes at 12 weeks. Within the Midlands, we are utilising information to compare outcomes of integrated systems to help identify local challenges and also have a focus of what good should look like.
So the foot care audit is administered nationally, happens every year since 2014. And what we get are these high-level infographics that we actually use and we discuss as a cohort, as a region, into how we can use the data and the changing data over the time. Every region in the United Kingdom gets these, but in the Midlands we really focus on using this data that's broken down to an individual integrated care system. And we have headline data that we circulate to our different organisations to make sure they understand where people are doing really well and where there are areas to improve. It is a challenge. And every year, last year included, we are constantly pushing people to make sure they're submitting data to the audit because it all relies on having that data. The audit gives us a high-level information, but we also want to look at the individual root causes of problems in individual cases. Dr. Murty will explain that now.
Root cause analysis across the network, and what we have found is this is a crucial bit of information from every trust where the service gaps can be identified by doing significant root cause analysis, especially of the amputations and near misses. And we find out quite a lot of deficiencies or easy fixes, and also there are a lot of processes and time-consuming coordination with the primary care involved in this process.
The backbone of our root cause analysis is the 7-day standards for patients with acute foot disease, that they have this process that they travel through, that we assess their standards against, and that is shared across the region. And it's crucial that this root cause analysis is not done within an organisation, it's not done within a hospital, but across organisations, and, as you've seen by different presenters already today, by a wide multidisciplinary team. Some of the themes that we found, and we can perhaps discuss this more later, are delayed referrals, delayed escalation, limited foot education in primary care by the healthcare professionals there, particularly the diabetes nurses, poor integration of ICT, limited offloading of foot disease, resistant bacteria, obviously, as many of you will share that challenge, and also inequality-related challenges that we see. People working in jobs that don't allow them to readily come within 7 days and go to a foot care service. But unfortunately, those are people who are likely to suffer the most from a foot ulcer or foot disease that's not treated early, because those occupations are often less able to flex what they do. There are, though, challenges to delivering root cause analysis.
There are a number of challenges with root cause analysis that we have found. Firstly, governance. We've required a number of permissions to work across multiple organisations, from primary care, secondary care, community and tertiary care. Secondly, IT. It is often not integrated. Therefore, we've required access, skills and training to multiple IT systems. Thirdly, implementing the learning. This requires a collaborative communication and embedding a learn, not blame culture.
So the audit and the root cause analysis look back in time. Peer review allows us to look at what services are being offered now and prospectively.
The peer review is introduced across the network. We introduced in 2 steps. One was doing a self-appraisal. This was looking at their service with the set standards by most of the Royal Colleges, and also looking at the NICE and other organizations with CQC. And then we looked at compared the self-appraisal with the current existing service spec. We also identified some areas where we went and visited the service and looked at both the good practices and also some of the areas where we can improve. This also helps in making the service equitable across the patch, and we have uniformed the referral process, the data analysis, and also outcome measures in these aspects.
So the peer review is structured. It's not just to go in, have a chat over coffee, much as we would love to do that, but we go through a series of different stages and steps to evaluate different services, share that learning, and it really is collaborative. None of this is sort of hostile, why aren't you doing this, you should be doing this. And actually services quite like it because it allows them to go to the leadership of their organisation and say, 3 organisations have come in and looked at our foot service. We need more resources to deliver this because of this reason, and we can benchmark that really easily. So it really does act to support people to drive change. We're really proud of what we've done in the Midlands Foot Care region, and we're trying to share that as widely as possible. But it's not a done journey. What we are trying to make sure is that this regional foot care network can be set up elsewhere, that actually we start to learn outside our region. What are other regions doing about their diabetes data, and how can we use that? Strengthening our peer review process so it's continual. At the moment it is slightly ad hoc, and really try to get that system level root cause analysis. So bring together 3 or 4 different root cause analyses. What's the shared learning on a system level, and how can we change that? So thank you very much for listening. Happy to answer any questions.
Yeah, thank you very much, Tim. And open for discussion. And I'm getting to you with my microphone if you have any questions or remarks from your experience towards food care. Okay. Please tell your name and where you are coming from.
Richard Coates from Alfred Health in Melbourne. I did miss the first 1 or 2 minutes, so apologies, but if you mentioned this, but having a high-risk foot clinic as a dedicated multidisciplinary service, is that widely considered a standard of care across the NHS, and is it both an inpatient and outpatient model?
So good question. So typically, yes. So multidisciplinary foot care services at an organisational level are relatively standard. Not every NHS trust has them, not every organisation has them, but a referral centre on a hub and spoke model is fairly standard practice. I haven't touched on the inpatient work. That's a whole new challenge and difficulty. Typically, though, these multidisciplinary services are based in larger hospitals, so that you do get the outreach into the inpatient environment. But I could give a whole presentation on how we would like to deliver effective inpatient diabetes foot care. And there's a gentleman called Jerry Raymond from the south of England, Ipswich, who's very passionate about that, making sure we're doing more screening. But this is more looking at that sort of outpatient multidisciplinary service.
Yeah. Just a question from my side. How many people, healthcare providers, are involved in the food care network you are organizing?
I think it's in the abstract. I think it's about 150.
150. And how the communication process is being done?
So we're very fortunate. We have the support from NHS England Midlands region. So that's basically the NHS England management team provide us with some administrative support for that, and they do a lot of the communication. But a lot of it is clinician to clinician. So before COVID, we had face-to-face peer review meetings and update meetings that were happening 2 or 3 times a year. Amazingly well attended, given that a lot of these are very busy multidisciplinary clinicians. That went on to Teams, but more recently we've moved them back to face-to-face again. And that personal interaction is what drives it. This isn't driven from the top. It's not driven by NHS England. It really is driven by all clinicians wanting to drive things together. One thing I haven't mentioned as well is that there is a patient involvement into this as well. That does tend to be at the organisational level rather than at the system level, but they're then feeding directly in, and Diabetes UK have a very powerful voice in terms of foot care, and we work quite closely with Diabetes UK, which is a charity in the United Kingdom.
And diabetes is as well a patient organisation, or it's more the clinic?
It's a national charity, so it's very much very much patient centred, but it does have a professional arm as well.
Okay. Any questions or remarks? I'm looking for the online presentation, so I'm going to see maybe there are some questions from the online version. Not at the moment. Then thank you very much, Tim.
Thank you.
Thank you, and we are getting to the next presentation. And unfortunately, I have to look again into my agenda. This agenda is a little bit complicated, right? So we always have to look again. So this presentation is now on. It's from Anouk Tuinstra and from the Hasselt University, and that's from Limburg, Flanders. So please go forward.
Hi everyone, my name is Anouk Tuinstra and I'm very honored and grateful to be presenting the CEL initiative today. CEL is short for Center for Primary Care Limburg, or Centrum Eerste Lijn Limburg, as we say so in Flemish. And I would like to start with just a short introduction about the primary care system in Flanders, which is the Belgium's northern region, because to tackle the fragmentation and bureaucracy in the existing systems, it was important to do a reorientation and restructuring of the primary care system. And a major aim was to create systems systems that support improvement in care integration over time. And at a local level, primary care zones were installed to support better coordination and connect care and welfare organizations with the local authorities, but also to help organize services for larger groups of the population, which is now also known as population health management. So just to sketch where we are coming from, in Limburg there are 8 active primary care zones, each with approximately 100,000 inhabitants. So Limburg is best known for being the friendliest but also the greenest province of Flanders, one of the 5 provinces of Flanders. But there is also a well-established tradition of collaboration between the healthcare and welfare sector and the knowledge institutions. And they both aim to further strengthen this existing collaboration to contribute to the further development of high-quality integrated healthcare and welfare support, specifically in the Limburg region, and with the primary care zones as a very important cornerstone in this story. So this is how the CEL initiative was born, just to sketch some of the background of the initiative. And what do you do when something new is born or a new initiative is started? You celebrate it, of course, but you also formally register it in some type of way. So we did that by signing a charter by all the partners, which you can see here with the signatures. But just to show you the level of commitment in Limburg to create better systems for integrated care, I would like to show you the amount of partners that actually signed the charter, which you can see. It's a very large group, a very large commitment to create better systems for integrated care. And with signing the charter, all partners signed the mission statement of CEL, which is that CEL aims to facilitate integrated care at a regional level through collaboration, knowledge exchange, and innovation. And I can hear you asking all these partners, well, how is CEL structured then? Let me take you through it. So CEL is a unique partnership between knowledge, which is research and education, practice, the healthcare and welfare organization, but also campus development as an innovative ecosystem. But CEL is represented by 3 large groups, which the green group is represented by the local primary care zones. So we have the 8 active primary care zones. Worth a mention that we started with 6 primary care zones, but after 2 or 3 months, the remaining 2 also joined because they really saw the added value of CEL, which is also a very nice and good development. We have in the blue color the local knowledge institutions, that is Hasselt University and the university colleges UCLL and PXL. But we also have cross-regional networks. So we have the prevention network, Logo Limburg, a palliative network, Palion. We have the 3 mental health care networks that are always also represented, and the 2 hospital networks. And also worth an important mentioning is that we also have associated partners in which the Flemish Institute for Primary Care, also known as FIVEL, is also an important partner and actively supports this initiative, and also is a member of our boarding management. And you can see in the middle, Health Campus Limburg. This is the campus development I was talking about, because in the future, we will have a physical landing place with CEL in the nice tower you can see here on the left, which will be a physical landing place and a meeting ground for primary care in Limburg. So we are very much looking forward to that. What is the vision behind CEL? To answer that question, we organized 2 strategic sessions with all of the partners, and this 4 strategic focus line are the result of that. So let me shortly take you through that. The first one is Learn and Connect. So CEL will form a learning network to exchange knowledge and develop new insights, solutions, or ways of working. It will do so because it will form a breeding ground for new knowledge and cross-fertilization. It also is a critical sounding board in a safe environment to explore challenges, put them together, and achieve breakthroughs for practice. We can see CEL as a smart connector because it connects the right partners around a certain challenge and form work groups for that challenge. And as I mentioned, it will be embedded in a regional ecosystem with the physical landing place in the health campus. The second strategic focus line is translate and implement, and I would like to talk that CEL is, I would like to mention that CEL can act as an innovation translator because it will translate evidence-based tools from the Knowledge Institute to hands-on tools for practice, but also vice versa. It will practice certain needs for practice to the knowledge institutions. And also, of course, policy objectives into joint actions at regional level. And it will contribute in that way to the broader and more sustainable implementation of knowledge in practice. The third strategic focus line is monitor and facilitate, in which CEL will keep a helicopter view on all initiatives within, with, and around the primary care zones to identify opportunities and or streamline joint initiatives. And it will also facilitate development and realization of project work in areas relevant to the sector. So this means follow up project calls and publicize them within the network, but also support the partners in preparing project applications. And then the fourth and final strategic focus line is what I am doing today, is inspire and disseminate. So we tend to expand, upscale and disseminate good practices. And CEL can be seen as a testing ground or a living lab for Flanders, but also the EU region. And we do so by sharing knowledge through dissemination activities. And just to close, I would like to show you some output of the CEL initiative. So in October, we had our kickoff and we submitted our abstract for the IFIC Congress. We also had a core management meeting. In November, we submitted our first project about return to work and the importance of the primary care zones in the return to work process. In December, we had the kickoff of our governance board and our return to work project was approved. In January, we developed our logo, so I developed it myself, so I hope I did a good job. But it's important, of course. The remaining two primary care zones also joined in January, so just a few months after the kickoff, and 3 projects were submitted for the Health Innovation Fund. Then in February, we held our 2 strategic sessions. In March, we drafted a living document as an action plan for CEL based on the strategic sessions, and it was approved by our governance board. We also have a kickoff of our Return to Work project, and 1 project that we submitted of the 3 for the Health Innovation Fund was also granted. And then in April, we submitted a first round for an Interreg project about remote clinical monitoring, and 1 work package will be fully designated to defining the role of the primary healthcare and the primary care zones in remote clinical monitoring. And we also had a kickoff for our palliative work group. And then today we are May. We are at the IFIC Congress, and we initiate a small work group about mental health care and how the future challenges that may arise here. So I just boxed it together as a summary, and yeah. Thank you for your attention and your time. And if there are any questions, I would like to answer them, of course.
Thank you very much, Anouk. And I think that could be a platform for other activities, for other regions as well. Yeah. But just to get an idea, did you have some monies in the funding for the start of CEL, or that was everything was done by the organizations themselves?
Yes, so the organizations themselves paid a certain fee for the Cell initiative, but there was also, how do you say it, an organization that was stopped because of the reorganization of the primary care zones, and the remaining money that was in that organization was put through to Cell. Through the initiative.
Just to have an idea, what was the amount of money that was?
Now we have the amount of money that we have now, I think, is budgeted around, we have 2 years that are budgeted now in a fund that is in the Hasselt University, and it's 2 times 190,000 euros plus the, so it will be around 250,000 euros.
And the people who are working in it, the administration and the management board, that is all paid by the organizations, right?
No, I'm the only one that is paid by the organization as project manager, but of course we are a network. So all the partners are it's one network, so all the partners are together in it with the same commitment, and I'm just coordinating the whole...
Okay, thanks. Questions from the audience?
Okay, Anne Hendry from Scotland.
Hi.
I very much appreciate your presentation. What a wonderful initiative. I've heard throughout the conference a number of examples of living labs, and I just wonder, do the labs network with each other and exchange learning across the range of different living labs?
Yeah, I think that's we're very open to exchange with other living labs, of course. So also here at the conference, that's one of the main connecting goals. But yeah, we just started, so we're still in the norming phase of the project. So we're focusing on putting our own vision, our own action plan in place. And then, yeah, of course, we're always looking for other initiatives to inspire us, but also to inspire them as well. So that's one of our strategic focus lines, though. So yeah, sure.
Kia ora, hello from New Zealand.
Hello.
My name's Anouk Maxwell from Collaborative Aotearoa. Mine isn't really a question, but it's really just to say that what amazing work in such a short space of time, and it will be your passion and your commitment that has got you there with your network. Our network of Collaborative Aotearoa does a similar thing. We have very small amount of resource, but a large network, and I really wrote down a lot of the things, so I'll be emailing you.
Okay,
But
yeah, very welcome.
Great work.
Yeah, thank you very much.
Thank you, Amarit. Any other question or remark? Okay.
Yes, thank you very much for a really nice presentation. I think Cell is mostly a network around knowledge right now, right? So like really focusing on spreading the knowledge that is emerging from the primary care zones. Does Cell also aspire actually, so have a vision to become also like an entity in terms of governance in a certain way? So connecting the 8 primary care zones in their governance, in their administration and stuff like that? Or is it primarily a knowledge focused network?
Great question. I think that's something that we are looking for now. So we're just starting up, but as in the future, we are looking how can we create a certain governance around Cell. So that's still an open question, but I think it's a very important question because there are certain evolutions in the landscape, and we're waiting what comes from that to align with Cell. At a regional level. So I think it's very important. And you're right that at this point it's knowledge based, because we see that there's still a large gap between the knowledge and the evidence-based concepts that are developed within the Knowledge Institute and the effective implementation in the practice. So I think the second strategic focus line, translate, is a very important one in the early stages, so that we can further develop the effective implementations in practice. So to bridge that gap, I think, is one of the major focus points at this moment.
Thank you. And I'm looking for the online questions, but there are none. So please engage in questions if you are interested from the online participants. And there's one question I would have to you again. Sure. You talked about the knowledge exchange, but how do you challenge or how do you develop the projects? Is there any kind of data that you are building upon so that you see there's a specific problem on mental issues or other issues in our region, or how do you develop these projects?
Yeah, great question as well. So we have a large amount of partners, and each of these partners has its own challenges within certain teams. And it's actually through the partners that throw up a challenge, and we look for, okay, how can we create a project or a work group for that challenge? So in this case, we in this stage of the project cell, we don't have specific teams yet on which we focus. We thought about it, but we saw that that was too early to focus on specific teams. So the partners come with certain challenges, or there are certain opportunities like the Health Innovation Fund, and we look in our network to see what type of challenges need to be tackled and how can we bring them to a project. And that's how the projects now are being set up or created. But it's also that in the ecosystem and within the Knowledge Institute, they also think about CEL in the project that they are submitted. So they ask us to be in to have some type of role in the project that they are submitted. So it's not that CEL is solely and individually submitted all this project, a large amount of it as well. But yeah, it's really through the partners and the commitment of the partners and the way that the partners find CEL and engage with CEL and contribute that now the projects are being created and submitted.
Last question about the communication process.
Yeah.
Because I know that all these care networks have always a lot of problems for the communication for all their ideas and things they are doing. How do you organize the communication for all the partners?
Yes, so we have our daily management, which is a smaller group, but we also have the larger group, which come together 4 times a year. And the way we manage the communication at this point is through the existing channels of all the partners. So we don't have an extra communication channel, but we use the existing channels to reach out as broadly as possible about the CEL initiative.
Okay, thank you very much.
Thank you very much.
So, again, the problem with the agenda. The next presentation, you know, and it's the next presentation. And Hendry is coming from Scotland, we know already. And Anne has been long time very strongly involved with the IFIC. So we know each other quite well through the board of IFIC. And Anne, your presentation, please.
Thank you, thank you. So although I'm from Scotland, I'm going to talk about some work that I had the privilege of being involved with in Brazil, and it was about expanding the concepts and the approach to integrating care within a couple of regions within São Paulo state. We called it Transforming Together. It was a pilot project in one region in Litoral Norte in the north coast of São Paulo state, and it was part of a wider health system strengthening project that the State Ministry of São Paulo was taking forward. That was of over 2018 to 2019 was the first pilot. And my colleagues from the University of the West of Scotland, the Health and Social Care Alliance, our IFIC Scotland team worked in partnership with the local team from São Paulo Ministry and from the Inter-American Development Bank. The aim was to build capacity and capability within the local professionals so that they could transform their own system. It wasn't us doing to them. It was very much, empowering them to transform. We used adapted breakthrough collaborative methodology to engage professionals from a whole range of different disciplines and across health, social development, housing, education, to work together and with civic society in a very cross-sectoral way. And together they designed, tested and implemented changes to create a more sustainable and integrated system within the regional health network. There were 5 main goals. It was capacity building, particularly to understand local needs in a very person-centred way, very holistic. Working with the local innovators, trying to identify local talent and spot the early adopters and innovators. It was very much around co-production, co-design. And really that was based in deep intentional listening to what mattered to local people. So really trying to get in and around local community, local neighbourhoods, very much like what we've heard throughout the conference. But it wasn't a plan on a page that was kind of implemented. It was very much an emerging iterative plan in response to what emerged as local priorities. And it was a train-the-trainer approach. We were trying to work with some of the local leaders to build capacity. Fabulous experience. I totally loved it. And I'm looking at a colleague in the audience from New Zealand. I think there's lots of parallels from my short experience in New Zealand with Maori Pacific and the guys we worked with in Littoral Norte. Family medicine, the family health system approach in the region is so powerful. We could learn so much in the UK from the model of very embedded family medicine with community health agents who truly were the integrators. They got to know the local families. They weren't just looking after an individual, as we do in UK medicine. They were looking after the whole family and the whole street, the whole neighbourhood. It was a super model. And very much working with community and voluntary sector assets in a very community development approach. So we worked with the multi-sectoral leadership, the schools, the housing, the mayors, the primary healthcare teams, and we supported them to really collaborate with local citizens to get that integrated care model. Lots of examples of integrated care working at point of care, joint visits between nurses and social development workers to really do social vulnerability mapping, working with housing providers, people who won't let healthcare in but let the man in to fix the roof or the plumbing. So how do we use those as the entry point to health promoting conversations? So lots of great work over the year. And reflections by participants around, they see that, the network is about people, it's not pathways. And understanding what everyone does, walking in each other's shoes was so powerful. And understanding that particularly the community health agents who are out in the field, they have the eyes and ears that can then spread that intelligence to all of the different health and social care professionals. And the phrase we kept coming back to was, none of us are as smart as all of us working together. We wrote all of our experience up in 3 handbooks that are available in Portuguese. They're available online on the ministry's website. And we thought, well, that might have been it. But then there was COVID. And then after COVID, we heard that another region within the state thought, this is really good stuff. We want to do it. And, the first follower is something really exciting. It's great to be early implementers, but when you start to get somebody else coming on board, you really know that the message is being heard. So another municipality in the metropolitan region, a slightly smaller area, but again, quite a deprived community, but with very strong already primary secondary care integration. and they were tending to consume their own smoke. They didn't refer a lot to tertiary services, but they had a new hospital opening. And like our first experience, the opening of a new hospital is a bit of disruptive innovation in a system where they recognised that they needed to change the way they work to make best use of that new hospital facility. So the challenge was to fully integrate the new hospital within the healthcare network. And what was really good was we took a back seat this time because the local team in São Paulo, they really led this project, and we provided a little light touch facilitation and remote support. But Larissa and her colleague, Mariela, led it from the front. And very similar methodology, a short diagnostic phase to really understand the situational context, and then providing technical support around the concepts of integrated care to system leaders from different professionals, different sectors, in a Train the Trainer programme. 3 stages of the diagnosis, really is of mapping of the healthcare network activity and service integration, getting an understanding of the gaps and areas for support, and then a programme of learning and knowledge exchange, a bit like the Living Lab work, knowledge into practice with the network professionals. And some focused work around flow within the new hospital using a tool that we've adapted in Scotland called the Day of Care Survey tool, which was particularly looking at who really needed sort of secondary or tertiary care and who could have care closer to home. Train the Trainer programme, we've all done that. Leadership development around people-centred integrated care, and it was lovely to see them really putting their own stamp on that programme. Nothing that would surprise you, 6 modules, building blocks of integrated care, leadership, management, how to engage and, inclusive participation, governance of integrated care, and then something about monitoring and evaluation. Again, a very short programme, which was, on the back of COVID, was difficult to deliver because there were still some elements of lockdown. So it was a hybrid programme, trained more than 100 professionals. Staff really got integrated care, they built relationships, and they had that deeper understanding of working with people and how to tackle the main challenges around integrated care. We used the lovely Sirocco tool, which my colleagues in Scotland have been leading the Sirocco project. So we used that for a bit of the maturity mapping. And not surprisingly, they were saying they were mainly at level 3, where they now had the knowledge and they were absolutely committed and ready and up for integrated care, which is not a bad position to be at the end of a 12 months. So what next? Well, the methodology works. It's transferable within the state. Different regions got it, used it, got behind it. It's not too labour intensive. It can be done through blended learning. And it did demonstrate an increase in capacity and capability of staff on the ground. So we reckon we're ripe for scale up across the state and hopefully across other states in Brazil and Latin America. Thank you. And sorry, I should have said the web link is to an Inter-American Development Bank webinar, which was for the whole of Latin America and Caribbean, which explains a bit more about the methodology.
Yeah, thank you very much. Just one question from my side. Bringing you from Scotland or Victoria from Vienna to Brazil costs some money. So how did you organize it? So
the Inter-American Development Bank were funding the São Paulo state, the huge, big, multi-million-dollar project, which was building primary care centres, hospitals, etc. On the back of some work I had done previously in Brazil around intermediate care and remodelling a sort of medium complexity hospital to be an intermediate care hospital, the bank understood that if they built these new shiny buildings but they didn't transform the network and the ways of working, then they wouldn't get optimal benefit. So it was a huge multi-million project. We got a tiny fraction of that money, which allowed us to do the 12-month first phase in Littoral Norte, and we mostly supported the local team remotely, but we had 4 site visits, 4 field visits from Scotland, which was a total privilege to do. You know, we went for about a week each time.
Okay, thanks. Questions or remarks? Yes. Your name and then.
I'm Hilde de Nutte. I'm from Belgium. I work in an umbrella organization of hospitals, and I have a question about your second example. So you have done a lot of sensitizing and education, but I'm wondering if it will lead or has led to specific actions concerning the building of that new hospital.
So in a sense, the building was already committed. They understood, they had done some modelling in terms of their population, demographics, projections. They knew they needed a sort of a local regional hospital, but they hadn't really worked out how they were going to use it in a way that maximised the flow between primary care and the new hospital. So we were able to influence their thinking around pathways of care, and also the concept of who actually was ready for care closer to home and could be stepped down from the shiny new hospital. Because the experience in the region had been that you build lovely shiny hospitals, the people will come, and they get full very, very quickly. So we were trying to promote the concept of flow home from hospital, and that was really important for them.
Thank you.
Some other questions or remarks? Yeah.
It's hugely interesting in terms of what you've achieved and what you'll go on to achieve. Do you actively use a collective impact, or what we term in Aotearoa New Zealand as collective action approach? Because obviously there's, it's flowing through, but is it an active application?
Yeah, so it's a really good point. We kind of used rapid breakthrough collaborative methodology, plan, do, study, act, learning cycles each quarter. But you're right, the overall theory of change was very much a collective impact model. We're very influenced in Scotland with outcomes-based approaches, contribution analysis, not seeing a linear attribution, but looking at the contribution of multiple factors in a very complex, dynamic, multi-sectoral landscape. So that was very much the methodology that we used.
Just to have an idea about the percentage of money that's being spent in the normal healthcare system from the Inter-American Bank, and the money spent into this organization of primary care and all the developments in the rural settings.
We had I would say less than 1% of what was being spent on the new shiny buildings. They were building new primary care health centres, a regional hospital. So it was a tiny amount of investment.
What you would suggest to be a percentage that is okay? Some numbers?
Sorry, maybe I wonder, did I pick up the question? Were you asking what percentage of the budget was on the transformation programme?
Yeah.
It was about 1%, something like that. Tiny.
Yeah. But what would you suggest for banks or for other organizations who do this kind of work? What should they spend?
Oh.
I'm just going to say that.
Yeah.
We're from Canada, and it's really grant funded that it is.
I can't do it. Sorry.
I think often for this type of work, it's based on grants, so there isn't ongoing. So it's pleasing actually to hear it's a 1% ongoing. If it's not?
No,
it was
it
one
was
time. Okay,
time limited. Yeah.
I mean, if we could get 1% ongoing, that would be a huge difference, right?
But shouldn't it be more than like 5 or 10%? Because that's the basics.
You will remember in Scotland the Reshaping Care for Older People programme. You might remember a number of years ago, and the Reshaping Care innovation funding was about 1 to 1.5% of the health and social care budget for older people. That was ring-fenced for transformation purpose for 4 years.
If you look into the German budget, I think it's about 300 billion euros for normal care and hospital care, every total care costs. And the percentage for integrated care is 0.001 maybe. So it's really a long development we have to tackle for. Thank you very much, Anne. And we are getting now to the next presentation from Shawna McGhan from Alberta in Canada. So please head forward.
Thank you. It's a real pleasure to be here and to represent my team. It's been incredible work to build community with primary care and really look at how we can address financial wellness. I'd like to acknowledge that this work took place on the traditional territories that are home to many of our traditional Indigenous and people. So just to give you a context, Alberta, we've got a lot of open spaces. We're about twice as large as Germany, and we have a population of about 4.5 million. We are one of the first integrated health systems in Canada. That means that we have over 100,000 employees that are all working under that umbrella. But as well, we've got 39 primary care networks that house family physicians and the primary care team, broader team. We worked in 4 rural communities that were fairly small, in partnership with their primary care networks. And you can see that they're scattered in the middle of the province and somewhat about 2 kilometers away from bigger cities. So one of the things that we were asking is, knowing that income is one of the most impactful factors addressing our health, what is it as a health system can we do, and how do we do that together with all the different sectors? And so really knowing that it impacts people's health in a way that those with low income are much higher risk of diabetes, cancer, the cardiovascular disease, mental health issues, etc. So we looked at what are those foundational supports that we can offer as a provincial team. I'm on the primary healthcare team that is provincial, but also at the zone level, and then at the local community level. And so how do we have collaborative conversations locally, but as well provincially, bringing all our learnings together? What does the training look like? So we provided training with all the teams, and then with the primary care teams and with the community teams. We also provided funding and support, as well as evaluation support. So we really looked at a asset-based community development. That was our foundational approach, where you can see in the circle we engage and connect with community, understand their local context, and then move forward. We also really took a human-centered design approach and used a lot of the principles that you'll see there. Acknowledging we want to be strength-based, focusing on what's working well, but also when you look at the evidence, really valuing the data and the evidence that we're hearing from the people and their lived experience. So a big part of the work was forming a local multi-sectoral community partnership. And you can see a diverse range of people from the community, from business to social sector to faith groups, and many different health teams that came to the table. We had 2 levels. Primary care looked at what matters to you at a patient level, so more that individual, and how do we have conversations about financial strain, social challenges with patient? What does that environment need to look like? And what's the patient flow? What's the team dynamic need to look like? But as well, we wanted to look at what matters to community. And so how do we bring partners together, create that collaborative environment, and allow them to set the agenda to do that? So I'll just walk you through the 2 different aspects. So the clinic teams really looked at how can we test ways to address income as a social determinant. And so we started with a tool that was developed across Canada and tested, and really essentially asked the question, do you ever have trouble making ends meet at the end of the month? That one question opened up a whole layer of awareness that the primary care teams didn't appreciate in the past. And then sort of guided through the introductions of what does that intervention look like. So they tested different ways, they shared together, they rejigged, adjusted things. Together they developed tools that they felt were helpful, what were the resources that were going to be needed, the training, and as well coaching on how do we embed this into our electronic medical records so we can track this and have across the team understanding. The shift in their approach in primary care and even just their efficiencies was very powerful. And in fact, 2 of the teams received awards for their approach in their patient-centered care. We also did a number of digital stories. We had a trained digital storyteller facilitator who was amazing, who we offered anyone who wanted to share their experience, whether it was patients, community providers, community partners, could do that. So I just want to share an excerpt of this story, really showing that in an analogy that if we don't address social determinants of health, it's like slapping paint on a falling building. We need to have a strong foundation before we can move forward. Take a listen.
We had planned to refer Mark to a retinal consultant, a healthy living class, a dietitian, and we're already thinking about different interventions we could use to mitigate his progressing diabetic complications. But instead, I turned back to Mark and asked, "What do you mean out of necessity?" He squirmed a bit, coughed, and with an awkward smile said, "Well, I don't have that bursary for school anymore, and I haven't been able to find a job yet. And my mom lost her job recently, so we just don't have a lot of money for food right now."
So we had, you can imagine if we had 37% of your patients in that experience, that you would be spinning your wheels in primary care, which is, our teams were really surprised how many said, yes, I have trouble making ends meet. Many of them accepted referrals into social and various layers of support, and also felt this is an important question. Teams felt this is actually something that's doable and something that's very relevant and easy to implement. So to give you a feel of the community, what did the community level teams do and in partnership with primary care? One of the first things that we did was a poverty simulation, and this shows a graphic recording of all the aha moments from this event. And it really transformed the thinking, for example, in the primary care team, who said, you go do that. I got too many medical issues I'm dealing with all my patients. And after participating in this, all of them put their hand up and said, we have to start with this. This is so important. So take a listen.
I don't think any of us expected it to be such a powerful experience. After years of having these conversations with others, I had a much deeper understanding of their daily reality. Many of us commented about how it was so exhausting to live with financial strain. And we only did it for an afternoon.
So there was so many ways that the communities came together, and they all did it a little bit differently. But this is an example of a pile of photos on the table. Choose one that represents where you would like to see your community financial wellness in 2 years. Many of them sort of looked around and said, where are the people with financial strain around our table? Invited them in. They weren't too keen to come in and be visible. And so they went out and had a coffee and talked to them and brought that back to the table in forms like the journey map, personas, sort of bringing that data into some real life context. Asset mapping was another very significant activity where they sat around a table and said, we really have nothing in our small town, walked around all the different stations, filled the sections with, we have so many services and resources we had no idea existed. And that was a powerful experience to just build relationships with all the different service providers, but also hear about what's the experience of the patients in accessing them. I'm really embarrassed. It's like Main Street. I'm not going to go there. I look after my own. So how do we change the mindsets in addition to providing those services? We also looked at a wilder collaboration factors inventory. So the community really looked at how do we collaborate, where can we grow and strengthen, and it was remarkable how the community said, this is how we move forward with anything we want to do in our community. This is really powerful work. So really we had a lot of collaborative action. There was a building financial well-being toolkit that was developed with our academic institutions. And you can see a sampling of some of the work that community did. Essentially, there was 60 different initiatives that took place. One community decided we need to have technology available. So laptops were purchased and made available on a loan system through the library. So there was a lot of partners and connections there. So a lot of key learnings. This was really hard to summarize, but really it's the deep wisdom that you can access from community, from all the partners. And when you give power to community, where you can go, they're still continuing this work today, and are really expanding where they want to go. This just gives you a taste of kind of an executive director from the primary care network saying that one question had a tremendous impact.
We have learned so much about financial strain, the community, and also a process we can use in other areas to continually improve the care we provide. In the end, it was so much more than just another question.
So we journeyed from kind of how to integrate and have power with, and you can see at the beginning we were all disconnected. We had silos. We were a big organization. How do we make sure we're not powering over? To kind of getting those connections, developing relationships, making referrals to services, to now we're feeling more integrated. We're working together. We're being collective in our action. So this is all of our work has been pulled into this website. You'll see our digital stories, our tools, and we're excited to really amplify the voices of our partners and share these stories. and look at how can we move forward together. We've actually got funding, support, I don't know if it's funding, but a promise of we want to invest in this provincially from our government. So it's exciting, and love to hear your thoughts on how you're doing this kind of work, and if you have any comments. Just want to quickly acknowledge my colleagues and all the various partners that were part of this. Thank you.
Thank you very much, Sean, for sharing with us these websites and these tools. So everybody, I think, will have to look into the presentation afterwards. And you know, everything is being recorded, so you may look into the websites being here in the presentations. Is there somebody from Antwerpen here in the room? No? There's one activity very much related to your work. It's a health kiosk being built up in one quarter of Antwerpen that is very poor area there. And I had been invited to go there yesterday morning. It's a tiny house on a square, and they offer food, so that poor people may come, learn how to take specific food and fruits on the one side, and salads and other things on the other side. And that's being brought by groceries who are in the last days of the possibility to use this food. So it's a very tiny house. It's a project from the University of Antwerp, but it was only for 6 months, and now they took it for 3 years now, and it's running out of money. And unfortunately, it's not being paid or financed by the sickness funds, because I would say that is a help for their medical services. But up to now it's not used there. So, your comments and questions. It was so convincing. Everybody is looking for it, for the one question that can be asked.
Thinking on my feet here, and we've obviously connected back in Canada, and the learnings are amazing. So this initiative, in terms of relating to the financial situation, there are other social determinants, as we're aware, in terms of that need to be addressed. Did you find that others could be, with a sort of, how do I put this, sort of additional benefits, additional kind of activities that you could cover off the income aspect and other things, because it's all related, isn't it?
Exactly.
And all of this effort that goes into this, you almost think you can ask what the other challenges are and start to manage that. So yeah, I'm not sure I've articulated very well, but it's...
No, absolutely. 100%, yes. And in fact, it's cool because now we're working with other partners. So our nutrition services are working with food insecurity. And so if you ask that question, they say yes, then what probes into, the food insecurity pieces? Same with housing. And so we're finding even just the conversation, what matters to you with that question, I couldn't get into my appointments, or I have trouble getting to work on time because I have to, whatever those situations are. So it does span, and with the technology loaning system, you've got employment opportunities. There were also housing conversations that occurred. So yeah, there was so many different layers. In fact, some of the primary care teams asked other questions. It sort of led to, we got to document all these other questions as well. So it really expanded to many of them.
So, okay. 2 other questions, but very short only.
Yes, thank you very much. My name is Stan Remers. I'm from the Netherlands, and I was wondering, in trying to translate your very promising results into maybe our system, in what way do you think that the fact that you did this in Alberta, which is known as a hugely integrated system, what influence does that have on the entire process? Because you describe really involved healthcare professionals, and I do feel that your system really helped in that. How do you see that?
Yeah, interesting. Well, I think we're still very siloed, even though like all of our the majority of our health providers are under one umbrella. Even within departments, there's still, you've got to constantly be working on how do you better integrate. And, I think what was powerful is, because quite often community never invited primary care. They're like, why would they want to talk to us or have time for us? They're so busy over there. And then primary care was like, we don't know how to reach people. We don't know how to connect with partners. We know all the medical referral pieces. So I think it was just coming together and look at ways you can kind of bring community together and just learn from each other. It was incredible, the kind of conversation. So I would say, that's powerful that anyone can do.
Thanks. And the next question.
If I may be so bold, I have two, one very small question and one bigger question. So one, as much time as you have, but one is around who in the team is doing the sort of journey with including I'm Sonia, also from Canada, so hi. So who in the team is doing the screening and that work? Because we all often hear about primary care being very burdened, not a lot of time. The second question is that it's great that this is surfacing the financial aspects and the financial need. This is when it comes to income and housing, those are very structural issues. So has there been conversations or has this spurred thinking with Alberta Health Service on their role in advocating for more healthier social policy?
Yeah, that's a good one. I think it definitely has. We're just implementing. So we're relating to the Alberta Health Services. How does it relate to policy? We're just implementing a fully embedded electronic medical system. And looking at this question and others in that medical system, so it's raising awareness and understanding, and also what action and who should be doing that. There's a lot of conversation now around what are we doing about social determinants of health? How do we understand that? How do we support patients? What's our response forward? How do we power with community? Instead of telling them, here's what we're doing. So your other question was around who in primary care. So we had, it was interesting because every community took a bit of a different approach. In some cases, it was the medical office assistant who put it on a chair in the exam room with a questionnaire and just asked to do that. And then the physician would take a look and have a conversation about it. In some cases, it was a nurse who was doing wellness checks, especially during COVID. They would call high-risk clients and they would ask that question. In some cases, they would say, for physicians, can you ask this, just try it on Thursday mornings. And it was so earth-shattering that they said, I need to ask every patient this question, and I'm going to do that, and then I'm going to pass them over to the nurse. We actually had employed community innovation liaison member who was working very closely with the primary care network, who is sort of like, here's what's happening in the community, here's some great services we want to connect with, and building those relationships. But it was really the whole team. Because one of the other things that the team did was, we're going to hire a social worker because we're so backlogged sending them to the community social worker, we're going to get our own. And so they just thought, let's send everyone who says yes to the social worker. And that person very quickly got overwhelmed. And so they built capacity for everyone on the team, at those encounters to be able to address those questions. So,
thank you very much, Sean.
Thank you.
when we started as a little bit a similar activity with the health kiosk in Hamburg, we used nurses for this, because nurses are more likely to be seen as equal partners instead of the doctors. The physicians, they are seen as a next level of ranks in the population. So nurses are the better interpreters for this kind of question, in my opinion. Yeah. So the next question stays with Canada, and it's Dominique Tremblay. She's coming from Sherbrooke, and please bring your presentation about cancer in Quebec.
Thank you for this, and I'm very happy to share with you the results of my research. Thank you to being here to listen about governance and cancer that are not so popular concept in our lives. So I will talk about collaborative governance in integrated healthcare networks, and these are insights we had from our research. So I'm not alone doing this. We have an academic researcher team, and we work closely with patient partners that are involved in the all of the research project and the research staff. And we were funded by the main funders in the province of Québec, the Fonds de recherche en santé du Québec. It's a quite regular overview, so you don't be lost into my project. So my objective is only to report some insights from providers and users on how collaborative governance takes shape in health services. I work on cancer issues, but I think it's now a chronic disease, and you can fit your mind about other type of chronic disease. And I try to focus on very pragmatic issues. There was a lot of content into this research, but I try to focus on the most important things, discussing with the patient partners and the research team. So there is a seminal work from the Institute of Medicine saying that in 2006 that patients with cancer were lost in transition, and we see 10 years later that it's still the case, while there's some efforts that are done with nurse coordinator, with patient partners and integrated network structures. So we see that there's something that goes on, but we now see that it's still the case, and the patients are still lost in transition. Some of them see more than 35 different care providers, and if we don't count the primary care providers and non-profit provider services. So we think that new solutions could be needed. And we look at the governance. We see that we look at the very micro level with nurse navigators and go wider. And in our province, the governance issues were not well addressed. So we try to look at this missing link and see if we could better understand how to coordinate the different level of the cancer network. It's aligned with the quintuple aims. So we want to make sustainable health for our patients, but take care of our professionals too, and try to reduce the cost for the health system and the out-of-pocket costs for the patients too. So it's rely on quite a regular objective of different health care systems. So there's many governance model, and the first one, the most classic one, was the one that called command and control governance. So it's from the top and try to go down with to percolate to providers, and we see that it's not the best model into professional care. Then we see the clinical governance model where the professionals were taking care of patients at the center, but in the previous session, a patient said that she don't like to be into the center because she feels like being in the zoo behind and looking at the people. So now we think that maybe a collaborative governance model could be a solution and bring the patient at the table, as well as professionals and non-provider care professional, non-profit care providers, and so on, to go with the real integrated care and avoid to lose patients in transitions. Okay, so a very quick part for the methods. I don't bother with you for that, but it's from our qualitative study. We interviewed different care providers and patients too that were involved into the cancer network and who were familiar with governance issues. And we also look at documents that were produced at different levels for direct care provision at the organizational level and at the whole network level too, and we perform coding analysis. So our analysis focused on framework, and we look at the main mechanisms around the red box, and we were interested looking at how we engage all the partners into the collaborative governance, what is the motivation to do that, and how they can mobilize for joint action. So it's the real focus we took for this part of the study. So results, we have three main tensions that arise from our results. I will go back for each one. Oops. Okay, so the first one is the top-down mandate, how we can live with a cancer program that is prescribed at the ministry level and make sure that it percolates on to the patient, so it's not easy to perform. And some says that it was positive because it gave the idea to go forward with more integration, but for some it was not the case, and they saw that there were unresolved controversies, and they feel that the committee at the ministry level serves the collaborative governance as a pipeline to transmit directive instead of being a place for exchange information. The second tension was with the patient partnership, and they look at how they can be in at the table, and it was very person dependent, and it goes back during the COVID-19 because the ministry argued that it was an emergency and they should take a very rapid decision for that, but patients say, we know what is important during this hard time and during the crisis, so continue to ask us. So there was a tension with that. And the third one is the latent controversies, and into this network there's pros and cons for the thing that's come from the top and from the bottom, and try to find some meeting points to make the things happen. But we see that we have all networks with small others networks at the local level, and it's not easy to make governance and involve each level. So, in conclusion, there is a strong potential with the National Cancer Program to focus on the structure at the beginning of the network. But if we want to focus on better integration and avoid the patient to be lost in transition, there's some other things to do, even if it's run since 20 years. So we should take the times to address the controversies and don't let them underground, because it constrains the way we can integrate the care for people. Thank you.
Thank you very much, Dominique, and thank you as well for getting into the problems of these projects. And that's very important for us if we try to replicate these projects, to be aware of the tensions and the controversies. Thank you very much.
Thank you.
So are there any questions or remarks from your work that you can share with us? No, not at the moment. Then thank you very much.
Thank you.
And thank you.
It's time for lunch.
It's now the possibility that all the presenters come onto the stage so that we make a photo and the others may go to coffee and lunch. Thank you very much.
Thank you.